Morning, friends, colleagues. We are into our 23rd session of the Clinical Neurology Forum, and it is happy to note that we have successfully conducted for close to 2 years. And I am indeed grateful and have great pleasure in having Professor G. Kumaresan. Professor G. Kumaresan, some of you may not have known him because he is out of the country for now for quite a few years. Professor Kumaresan was the first pediatrician to do DM neurology, as far as you know, in this country. And he was professor of neurology in the Institute of Neurology, and later professor of pediatric neurology and head of the department at the Institute of Child Health, Egmore. And it also doubles my pleasure to have the team from CMC Vellore, where they have the first pediatric neurology DM in South India. And Professor Maya Thomas is heading the department as the professor of neurology. And she has with her Sangeeta, who is the associate professor also. And we are very happy to have the team. And now I'll hand over to Professor Kumaresan to conduct the proceedings. Sir, you may take over and conduct the proceedings, sir. Thank you, sir.
Thank you, Natarajan. Congratulations. In the COVID era, you have done a great job of conducting 22 clinical forum.
Sir, good morning to Lima Paulin, sir. Lima Paulin has joined, sir.
Welcome, madam. Welcome, Dr. Lima Paulin.
Welcome, sir. Good morning, sir.
Welcome,
good morning,
Lima,
everyone.
Welcome, madam. Welcome. So, thank you. Now, we are entering to the 23rd clinical forum, and extremely happy that we've been focusing on pediatric neurology. I welcome Dr. Maya Thomas and ask her to conduct and moderate IBLs. She'll be helping me and moderating. Over to Dr. Maya Thomas, please.
Thank you, Dr. Natarajan, for inviting us to present this case series. And I'm really privileged to have Dr. Kumaresan as a chairing this session for us. So without much ado, we'll go on to the cases. We have 4 cases for this morning. So we will have 2 acquired cases and then 2 genetic cases. So can you hear me?
Yes, of course.
Yes.
Yeah. So we will start with the first case by Dr. Sushma, who's a pioneer resident in the department. Over to you, Sushma. We will have half an hour for each case. So at the end of each case or in between also, if anybody has any questions or comments, we are most free to share.
Good morning, everyone. Am I audible, ma'am?
Yes.
Yes, Sushma, you're audible. Yeah. You want to put it on slideshow? Yeah.
Good morning, everyone. Our first child is a child who presented with droopy eyes and was very sleepy. So going into the case, he's Master X, who presented to us at 3 years 10 months of age from Tirupati, Tamil Nadu, with complaints of sudden onset of drooping of left eyelid, nasal regurgitation of feeds, respiratory distress, and altered sensorium for 1 day. So he was apparently well, and then on waking up, he was noted to have cold cough and low-grade fever, and mother also noticed that he had drooping of left eyelid. Then otherwise he was interactive and was doing his physical activities. At around 10 a.m. he developed one episode of non-projectile vomiting, and then when given a glass of water, there was nasal regurgitation of water. Mother also noticed that child had a change in speech and there was nasal twang to it. And gradually the child had become lethargic and hypersomnolent. And within next few hours, he had developed floppiness of all 4 limbs, and he had difficulty in getting up from supine position, rolling sideways in the bed, raising hands or legs off the couch. And then so he was immediately taken to the hospital, where in next few hours he developed breathing difficulty, and he also developed one episode of paroxysmal event characterized by upward gaze with lapse of awareness that lasted for less than 2 minutes. Then he was referred to CMC for further management. So otherwise, there's no history of diminished vision, double vision, or facial asymmetry. No history suggestive of any involuntary movements, abnormal sensory sensations, or bowel bladder involvement or autonomic disturbances. There's no history suggestive of toxin exposure, trauma, recent vaccination, animal bite, or diarrheal illness preceding the event. He did not have any sore throat, nasal discharge, or neck swelling prior to the prior to this illness. Since it was a COVID time, we've also asked for any contact with COVID infected people, and that was a negative history. So this otherwise family history was nil significant. Antenatal perinatal period was uneventful, and he was a developmentally normal child, and he was immunized up to age according to the national immunization schedule. So summarizing the history, he's a 3-year, 10-month-old boy, second born to non-consanguineous parents with uneventful antenatal period, premorbidly well child who presented to us acutely with history of rapid progressive descending weakness, starting with the ocular involvement, bulbar respiratory muscle involvement, and flaccid quadriparesis. There's also history of low-grade fever, one episode of seizure, and altered sensorium without bowel, bladder, or sensory involvement. So based on the history, we localized the lesion to brainstem or polyradiculoneuropathy or neuromuscular junction. And the etiological differentials we considered include viral rhomboencephalomyelitis, parainfectious ADEM, Bickerstaff brainstem encephalitis, neurotoxic snake envenomation, diphtheritic polyneuritis. Although there's no history of any contaminated food ingestion, based on the pattern of involvement, botulism was also considered. He did not have any prior episodes or weakness. So acute myasthenic crisis is also considered as one of the differentials later down the line, down the list.
Dr. Kumresan, any comments at this point? Or any
has done a good summary. Let's wait and see. To me, it looks more like a brunt to the brainstem, and it seems to be very acute, evolving over a few hours. So the acute brainstem would probably be by my guess.
Madam Dr. Maya, I have one sort of a question.
Yes, sir.
We have listed 3 sites of localization: brainstem, polyradiculoneuropathy, neuromuscular junction. Where do we fit in the seizures, or is it an independent site of lesion going along with major core of the problem being in one of these sites?
So a seizure, he developed seizure only after respiratory distress and decryptus sensorium. It could be a secondary to hypoxia.
Okay, so you think that's an independent problem? Seizures, we need to keep it independent and then take the core features and localize either to the brainstem, polyradicular, multiple radicals, or neuromuscular junction.
Yes, sir.
That is what you have done, isn't it?
Yes, sir.
Yes, acute
Okay,
respiratory failure and maybe some mild hypoxic seizures. Yeah.
Was she put on the ventilator?
Yes, sir.
Yes,
Okay.
sir. She'll just come to that. Yeah.
Okay. Right. Thank you. Sir, there are other, Professor Kumarasan, sir, there are pediatricians in the group. Whenever you want, you can ask them. Yeah, there are about 56 people who have joined so far.
Oh.
No, it has gone to 62. So you can ask them.
Anyone who wants to commit at this time?
Any stage, sir. Any stage. At any stage. Let her finish and then also you can ask.
Okay, right. Okay, please carry on.
So when we examined the child, he had depressed sensorium with impending respiratory failure. So he was intubated, and then his vitals were GCS was E3, VT, M5. He was hemodynamically stable, and there was no feature suggestive of autonomic instability. Anthropometry, he was wasted, stunted, and head circumference was between -2 to -3 standard deviations. We have on examination, we have looked for cervical lymphadenopathy because we considered diphtheria as one of the possibility. Throat examination was normal, and there was no evidence of snake bite, dog bite, or Escher. So neurological examination, so pupils were equal and reactive, fundus was normal. There's restricted ocular movements in all directions, and there's bilateral ptosis. Corneal reflex is present. There's bifacial weakness with pooling of secretions and weak gag. So, and motor examination, bulk is normal. Tone was reduced, both axial and appendicular tone. And power, observed power, there's reduced in symmetric decrease in power in all four limbs, proximal more than distal. And reflexes were, there was areflexia in all four limbs with plantar bilateral flexa. There are no signs of cerebellar involvement, meningeal irritation signs, and skull and spine normal. Other system examination is also normal. So after this is the initial video of the child when we admitted. I'll just play the video.
So the child was intubated on admission to emergency, Dr. Sushma?
Yes, sir. Yes, ma'am. He was intubated after admitting into emergency. This is him in the PICU, where we can see ptosis and then the abnormal pattern of breathing. So after examination,
how did you determine this ophthalmoparesis in this child?
Ophthalmoparesis, because there is bilateral ptosis. He's actually trying to move his limbs, but there's ptosis bilaterally with restriction of movements.
How did you demonstrate that? You used a Doll's-eye maneuver.
Yeah, Doll's eye is negative.
Yeah. What about the pupillary reactions? How are they?
Pupils are reactive, ma'am. Equal and reactive.
Yeah.
It is external ophthalmoparesis.
So what would you call this? Yeah. What was the type of ophthalmoparesis?
External ophthalmoparesis with pupillary sparing, ma'am.
Yeah. Okay. When do you say there is a total ophthalmoplegia?
When there's pupillary involvement along with complete restriction of extraocular muscles and ptosis.
Okay. So here the pupils were spared, huh?
Yes, ma'am.
Okay. Okay, go on. Any other questions, comments, anybody?
Yeah, I think people can comment. People can think of what, tell them what possibilities they're thinking of.
Yeah. Okay.
Was the ptosis equal in both eyes? Was the ptosis equal, or was there was it uneven, unequal?
On examination, it was equal, symmetric, sir. Ptosis bilateral equal.
Okay, as an adult neurologist, I'll venture out to say that probably this looks like a overlap of Miller-Fisher and Guillain-Barré. That would be one possibility. The other one would be ADEM. As an adult neurologist, these are the two possibilities I would think of. Then, of course, there are pediatric neurologists who can join in and pitch in with their diagnosis.
Yes, sir.
Sir, you can. Lima has joined. Yes, Lima, madam.
Okay, please.
Doctor, you had bifacial weakness. Still, the corneal reflexes were preserved.
Yes, ma'am.
You can elicit the corneal reflexes. So, is it so? You had bifacial weakness. And another thing is the power in the lower limbs were so low, but the plantars were flexa. And again, cerebellar signs we tend to examine when the power is at least 3.
The distal power is like 2 by 5.
You can't really comment, isn't it? Cerebellar, yeah.
Yes, ma'am.
You can't comment. These are the things. And
Yeah.
with this clinical findings, ours will be first of all polyradiculopathy. Would be the first point, but the point is which is not in favor is the altered sensorium, and as sir has told, then we have to involve the brain as well to say whether could it be an ADEM or a bigger stuff. That will be my first possibility. And of course, always any acute onset of oculofaciobulbar palsy until proved otherwise is snake conformation, which and altered sensorium could be examined, could be explained by the complications of neuroinflammation such as associated encephalopathy, or it could be other possibilities like your vascular. If the snake envenomation also has evidence for vasculotoxic involvement, then we can have associated intracerebral hemorrhage, something like that.
Okay.
Yes, Dr. Lima. Yes, thank you. Yeah.
Now, let's reconsider the history. He had a palatal palsy, but he was fully conscious. He had ptosis, he was fully conscious. So the initial insult was on the brainstem. Flaccid weakness with air reflex could still fit into an acute brainstem lesion. I think the core lesion I would like to keep it is in a brainstem lesion. In combining your Miller feature, all those you will get into bigger stuff. Encephalitis would probably my first commitment. Yes, sir.
Megandan sir. Megandan sir is there. Ramakrishnan is there.
Sir Ramakrishnan.
Yes, Rama. Yes.
Sir. Clinically,
Yes,
I think it's more likely to be polyradicular neuropathy, sir. Probably a descending type because more of Miller-Fisher plus syndrome, ophthalmoparesis with quadriparesis and areflexia. That is what I clinically feel, sir.
Sir, Professor GK, sir, Ramakrishnan is a Ramakrishnan is a pediatric neurologist working at KG Hospital, Coimbatore, sir.
Sir, I know it's. I was Kumaresan sir.
Yes, I know.
Okay.
Thank you.
Sir.
Okay.
Thank you.
Good morning, Kumaresan sir. Good morning.
Thank you, sir. Thank you, Megan.
I'm very happy to see you, sir, after a long time.
Thank you.
How is your health, sir? Coming back to the case, it's very interesting that you have rightly pointed out that it is more in favor of a brainstem lesion rather than a. But the only thing which is a hitch which I find is the conscious state in a brainstem. As Madam pointed out that we have seen several cases of neurotoxic snake envenomation acutely with bulbar palsy, with generalized weakness, and with that is myasthenic possibility with absent reflex is very rare. And diphtheritic polyneuritis we have not seen for a long time, for nearly some 15 years probably. One or two cases of diphtheria has been seen. Diphtheritic polyneuritis is a differential diagnosis. I don't think nowadays it is still, though we can think of, but still it should be kept as a last rather than you can keep the other things in the front. What is your opinion, sir? Brainstem involvement without conscious, because consciousness will go first before involvement of the palatal palsy and everything. So I still feel the neurotoxic snake envenomation, where we don't get a history of snake poisoning, snake bite, or sometimes we don't even get any history of snake envenomation, but the patients are brought. Previously, it was thought like some early morning paralysis, something like that. And we have seen several cases like that coming, and in spite of intubation, everything, we have lost children some long time back. But the ADEM with respiratory paralysis and other things is not very possible, but still the envenomation tops the list.
Sushma.
Okay, Sushma, you can carry on.
Madam, one question for Sushma. Sushma,
Yes,
where did the patient come from and what was the host surroundings? Because as Megan pointed out, yes, snake envenomation is a distinct possibility. So we need to know the circumstances of the house as well as where the patient came from.
So patient is a resident of Tirupattur, sir. Tirupattur, Tamil Nadu district. And then they live in a attached house.
Oh, that's important.
And
yes.
And Sushma, you are the one who presented the case series on diphtheritic polyneuropathy, isn't it?
Yes, ma'am. Yes, ma'am.
So how many cases and how many of them had polyneuropathy? Would you like to say at this point?
Yes, ma'am. So we have studied over last 10 years, ma'am. We have got total of diphtheria cases of around 72, of which 10 developed diphtheritic polyneuropathy, either isolated bulbar palsy or bulbar palsy plus quadriparesis. So we had a case in last year as well.
Yeah, so it's not uncommon, sir. So we do see, especially with after COVID and inadequate immunization. So we do see there is a resurgence of diphtheria actually. Okay, Sushma, I think we'll carry on because
was there any history of fever or throat pain or throat? Oh, sorry, sir.
Right. Sorry, you can answer. Sorry.
Was there any history suggestive of sore throat or your suggestive of diphtheria earlier in this child, 3 weeks
no,
or 5 weeks earlier?
Yeah, preceding the illness, there's no history of sore throat or neck swelling and throat examination.
Any throat pain or sore throat for which the child got admitted, diagnosed as streptococcal tonsillitis and would have received only a penicillin or penicillin group of drugs for 10 days and sent home without being diagnosed as diphtheria.
No, ma'am, no such history, ma'am. We've asked for that.
Child was
in this particular child, there was no sore throat, but this is one thing which we should definitely think of.
Immunized child?
Yes, ma'am, fully immunized. He's 3.5 years.
Sorry, Dr. Sushma, one question. Theoretically, diphtheritic polyneuropathy has a descending course of events, isn't it? With it expanding over a few days, not such acute onset of within a few hours. They usually have a ocular followed by a little slower in evolution.
Yes, sir.
Absolutely.
This acutely.
Yes, sir.
Yeah, go ahead, Sushma. I think we.
Sorry, it doesn't involve the sensorium. We haven't seen any child with a post-diphtheritic who has involved the encephalon as well.
Yeah, understood. But of course, diphtheria, like Sir mentioned, it is usually, like almost like a biphasic. They have a bulbar paralysis and then subsequently they develop the placid quadriparesis. Yeah, go ahead, Sushma. You want to discuss the possibilities?
Yeah. So as we've already discussed, so our possibility since the start, child also had fever. We considered viral encephalomyelitis. So points against were for a myelitis, there's no sensory level bowel bladder involvement. Para-infectious Adam, again, because he had fever, encephalopathy, and an episode of seizure with multiple cranial nerve palsies and hypotonia with areflexia. We've considered because of brain cell encephalitis, as we have discussed that a child had altered sensorium, external ophthalmoparesis, flaccid quadriparesis with areflexia. However, in the initial part, he did not have any ataxia in the initial few hours. Then we considered neurotoxic snake envenomation as well. Because he presented with external ophthalmoparesis, bulbar respiratory muscle involvement, and flaccid quadriparesis, there's no evidence of snake bite as such historically or on clinical examination, and he also had a fever at the onset of illness. So other less likely possibilities we considered were again diphtheritic polyneuritis, although he did not have any history of sore throat prior 4 to 5 weeks prior to the onset of this illness. And then other possibility we considered was myasthenic crisis because of the ocular, bulbar, and respiratory muscle involvement and flaccid quadriparesis. However, he did not have previous history of any fatigability, and then absent reflexes at presentation again is not pointing towards myasthenic crisis, and encephalopathy at presentation.
Sushma, there's a question on why not botulinism?
So historically, he's not one thing history-wise, did not have any consumption of this contaminated food or canned food, and examination-wise, pupils are spared. Usually in botulin toxicity, pupils are involved. So
also present predominantly initially with GI symptoms, isn't it?
With constipation.
They can have abdominal cramps, and then they can have constipation, and then they go on to develop a descending paralysis. But that was also considered, but unfortunately, we've never seen, we've suspected botulism, but never seen a case of botulism. What about you, Dr. Kumaresan? It's always discussed for theory purposes.
I think only one case of botulism. I think the pupil was a clue.
Yes, sir.
Yes, ma'am.
One thing is pupillary involvement, and second is GI symptoms. Yeah. Yes, Dr. Lima.
Yes, ma'am. Infantile botulism is the commonest one, and another history is anything given along with mixed with the honey, because honey is the one who is who can have this botulinums about spores and all. Another one is we have not seen. Have you seen, madam, any clinical case of botulism? Sarah has told you have seen only one so far in the last few.
Yeah, we've never.
We
even same here.
But we used to consider this one as a possibility in every case of dysenteric paralysis, but we haven't seen any such case. Yeah, ma'am.
Absolutely. Yes, yes. Go on, Sushma. Go on to the next slide.
So we have worked up this child. We've looked into the routine blood investigation, including serum potassium, which was normal. We have done diphtheria, throat swab, and PCR, which was negative. COVID antibodies were positive. And then imaging, we have done MRI brain with contrast. It was normal. EEG showed bihemispheric slow wave disturbance. Nerve conduction showed decreased CMAPs. In bilateral facial nerves, bilateral median, ulnar, and perennial nerves with normal conduction velocities and latencies. H and F wave latencies were normal. We have done CSF analysis following the imaging, which showed normal cell count of 5 with elevated protein. There is albuminocytological dissociation. Other cultures were all negative. So we have suspecting Bickerstaff encephalitis with GBS overlap. We have sent serum anti-ganglioside antibody, which was strongly positive for anti-GQ1B antibodies. So final diagnosis of this child, we've kept as acute encephalopathy, external ophthalmoparesis, bulbar and respiratory muscle involvement, flaccid quadriparesis with areflexia. So we have considered Bickerstaff brainstem encephalitis with GBS overlap because of features suggestive of both CNS and PNS peripheral nerve system involvement. So we have treated this child. We have given the respiratory support. He was mechanically ventilated for almost 10 days. After that, he was extubated. Intravenous antibiotics, and we have given IVIG 2 grams per kg over 5 days. So extubated after 20 days. Along with nutritional care and physiotherapy, he's improved, and at discharge, he was alert, awake. He was discharged on nasogastric tube feeds. Ptosis and ophthalmoparesis has improved significantly, and this the facial weakness resolved. Power observed was around 3/5 in all 4 limbs. Superficial abdominal reflexes were present. DTR was absent, and modified Hughes score was 3 at discharge. At this point, I would like to show the videos of the child.
Dr. Sushma, how long did it take for his sensorium to improve?
Sensorium had improved within a week, ma'am. But for extubation, he took around 20 days.
Okay.
For extubation. I'll just show. Sorry, the video is little sideways. But this is after
at the time of discharge, whether all the cranial nerve symptomatology subsided?
Yes, ma'am. Significantly improved. Facial weakness improved. External ophthalmoparesis also improved, ma'am. Is able to walk with one hand support.
Ophthalmoparesis, everything improved.
Yes, ma'am. But
he still had some bulbar weakness, isn't it? So he was sent home on nasogastric feeds. Yeah.
Later,
1 month of IVIG itself, all this improvement was there.
Yes, ma'am. We have given 1 course of IVIG.
Nice.
Yeah, she will just briefly discuss about Bickerstaff, and we'll move on to the next case. You can.
Okay.
This antibody levels you could do in your institution itself, ma'am.
Yes, ma'am. They do that full anti-ganglioside panel. Sushma, you want to say what all do they check for?
Only 1 second. Can you just repeat the nerve conduction studies and the late responses? Was it in favor of GBS directly?
Late responses were normal.
Normal. Only amplitude was reduced, sir.
The amplitude.
That is not in favor of GBS, though the antibody. So
yes, sir. It was more like a motor axonopathy, sensory motor axonopathy. Was Snaps also involved, Sushma?
Snaps are normal, ma'am. It's like motor axonopathy.
Yeah, more of a motor axonopathy. But there was albino-cytological dissociation. The thing was, the nerve conductions were also done rather early in the illness, also probably because of that, sir.
Even then, no, the early response will be definitely seen, even before because GBS is diagnosed mainly by that one.
Yes, sir.
Even the diagnosis. I think that is one thing which is not, again, the recovery pattern within such a fast recovery, we don't see.
Sir,
So that is the beauty about the GQ1.
Exactly.
The GQ1s tend to respond, recover rather early, other than the other antiganglioside antibody associated disorders.
Professor Maya, I wanted to say the same thing. Professor Megan,
Yes, sir.
sir, when it is a GQ1B antibody Miller-Fisher syndrome, that's what said, Miller-Fisher overlap with GBS.
Yeah.
In that situation, the recovery is quite fast.
Very
unlike
good.
the classical GBS.
Other than the GD1 and all that. Yeah. Yes, Sushma, carry on.
Yes, ma'am. So diagnostic criteria for acute encephalitis includes one major criteria, that is the patient should have an altered sensorium for more than 24 hours, and two of the minor criteria is required for to consider as possible encephalitis, 3 or more for confirmed encephalitis. The minor criteria include elevated fever more than 38 degrees, seizures which could be either focal or generalized, and new onset focal neurological deficits, CSF leukocyte count more than 5, abnormal imaging or EEG findings. Etiological considerations for AES include both infections and non-infectious causes. Infection again includes viral, bacterial, fungal, and parasitic. Non-infectious include ADEM, immune-mediated encephalitis, collagen vascular diseases. In our child, it is a immune-mediated encephalitis. Brief about a discussion on Bickerstaff brainstem encephalitis. It's an immune-mediated disorder which mainly involves the brainstem. Usually, there will be preceding respiratory or gastrointestinal illness caused by most commonly involved organisms are Mycoplasma, pneumonia, Haemophilus influenza, Campylobacter, and this is because of a molecular mimicry between GQ1B gangliosides and lipooligosaccharides of these organisms. So basically, in the spectrum, predominant PNS involvement is seen in Miller-Fisher variant, whereas CNS involvement is seen in Bickerstaff variant. So the triad of ophthalmoplegia, ataxia, areflexia that we see in Miller-Fisher syndrome is mainly because of antibodies acting at the muscle spindle level and also at the oculomotor nerves. And in Bickerstaff, because of antibodies acting at reticular formation in the brainstem, there is impaired consciousness in Bickerstaff. So this is a spectrum of anti-GQ1B antibody syndromes. So it can include predominantly peripheral nerve system, as in Miller-Fisher variant, or as predominantly central involvement, as in Bickerstaff brainstem encephalitis, or an overlap syndrome with GBS. So these are the various overlap syndromes. And then on comparing Bickerstaff encephalitis with Miller-Fisher variant, both of that can have ophthalmoparesis, ataxia, and areflexia, but the sensorium is impaired in Bickerstaff encephalitis, as we discussed, because of the brainstem and reticular formation involvement. Laboratory findings also show positivity of anti-GQ1B antibodies with CSF pleocytosis and albino-cytological dissociation. MRI findings are usually MRI finding is normal in Miller-Fisher variant because it's predominantly the peripheral nerve system involvement. In Bickerstaff variant, MRI may show signal changes in the brainstem and basal ganglia. So this is one of the review of systematic review that was done, including 52 children less than 20 years who satisfy the triad of ataxia, ophthalmoplegia, and altered sensorium. So in almost 90% of the children had preceding illness, either URI or gastroenteritis. And then the clinical presentation along with the triad, the most common presentation was hypo or areflexia with facet paresthesia and bulbar palsy. So the investigations, CSF show albumocytological dissociation, and imaging majority is normal, but can have T2 flare abnormalities involving the brainstem and basal ganglia. EEG shows bihemispheric flow wave disturbances. Again, EMG is axonopathy is more common when compared to demyelinating pattern. And in 2/3 of the cases, anti-GQ1B antibodies are positive. This is again the study where they've the abnormal EEG and GQ1B positivity is seen in around 60 to 70% of the children, and almost all the children had albumocytological dissociation. 32% had albumocytological dissociation. Maybe they had done in the early course of the disease process. So treatment, because of encephalitis has a very good prognosis with usual recovery within 4 to 6 weeks of beginning the treatment. The treatment mainly involves IVIG and plasmapheresis. So in the study, they have tried IVIG alone, IVIG with plasmapheresis, and also steroids. Or supportive treatment. They found that with treatment, the recovery is faster in these children. So there's an approach to child with encephalitic presentation. So based on the history and examination, as we have seen the diagnostic criteria, the diagnosis of acute encephalitis syndrome is made. MRI brain with gadolinium followed by CSF, including cell count, protein, glucose, cultures, and then EEG is done. If it is suggestive of an infection, treat with appropriate antibiotics. If it is negative for infection, then based on the other symptoms, if it's psychiatric symptoms, seizures, and extrapyramidal syndromes and autonomic disturbances predominate, then the possibilities to be considered include autoimmune encephalitis, and then antibodies for vasculitic panel has to be done, thyroid screening, and metabolic screening if extrapyramidal syndrome predominate, and the treat etiology based on the reports. And if the presentation has predominantly encephalopathy, ophthalmoparesis, ataxia with flaccid quadriparesis, then nerve conduction with and anti-GQ1B, if available, can be done. And then based on the diagnosis, we can treat accordingly with IVIG. If no response, plasmapheresis can be tried. Because of encephalitis is a rare condition that must be suspected in children who present with ataxia, ophthalmoplegia, and central nervous system involvement in the form of either altered sensorium with or without pyramidal signs. So Miller-Fisher, GBS, and Bickerstaff, they are considered as a part of a same spectrum of disease, often triggered by an antecedent infection. So the treatment mainly comprises of IVIG and plasmapheresis, with most patients making a good recovery. The prognosis of simple Bickerstaff is good when compared to these overlap syndromes. So we'd like to thank our clinical microbiology team for helping us with the serology and guiding us in the diagnosis.
Thank you, Dr. Sushma.
There's one question raised by Dr. Kumar. Can you answer how long do you wait before plasma exchange? A practical question.
So usually after giving IVIG, children would respond within a week, 1 week to 10 days. Then we can give a second dose of IVIG, or if he's worsening, can consider plasmapheresis.
This child being a very small child, generally plasma exchange is safe, but even then we would prefer to treat with IVIG, and like was mentioned, the responses are quite good.
Yes,
Thank you, Dr.
Actually,
Sushma.
in children, we tend to go for second IVIG rather than Plex, and take half
Yes.
of IVIG is minimum 2 weeks, that is 2 to 3 weeks. So if at all we are planning for Plex, we have to at least wait for 2 weeks. Otherwise, whatever IVIG we have given, we will be removing by Plex.
Absolutely. Yeah. Thank you. Thank you.
Good.
Next
Thank you.
case.
Sorry.
Can we move on to the next case, sir?
Please. Good. It was a good case.
Okay.
Thank you, Dr. Sushma.
Thank you, sir.
The next case will be moderated by Dr. Sangeeta, and Dr. Fazil will present the case. Sangeeta, you're there?
Yeah. Yes, ma'am. Good morning, everyone. Fasil is a second-year fellow in pediatric neurology. He will be presenting an interesting case of superrefractory status epilepticus. Over to Dr. Fasil.
Any further comments while the slides are coming up?
Only one comment that I would like to add, madam.
I want to make a comment.
Yes, sir.
madam.
Yes, sir. Tell, sir.
Of the previous
Regarding-
previous case, that you mean to say that the case that the patient was suffering from brainstem encephalitis and Miller-Fisher syndrome and GBS all together, or is it only Miller-Fisher and GBS alone?
So here, I think we would probably call it like a Bickerstaff encephalitis with the GBS.
With
Meghandan
Miller-
sir, the best way to classify or diagnose is GQ1B antibody syndrome. That's all.
Yeah, that is the
I think
that would
that
be
is
the
better,
current
yeah.
terminology, which would encompass this overlaps.
Is there any evidence that the GQ1B affects the cortex also to explain the seizures? Is there any case report of seizures?
loss of consciousness and involvement of the brainstem. Yeah.
Yeah,
Why
that is
should
mainly
the
because
GQ1B
of
is also gone.
brainstem.
Cortex.
It is not seen in
The
anti-GQ.
reticular activating system impairment. So because of that, they have altered sensorial.
No,
Somebody is asking why only external ophthalmoplegia. So actually, you can have this GQ1B antibodies also involving the parasympathetic supply to the eye. So as a result of which you can also get a total ophthalmoparesis, not just external ophthalmoparesis.
Historically, it's an old concept. There are a lot of controversy whether Miller-Fisher is a lesion of the brainstem or a lesion of the peripheral nerve. This would probably tell you the overlap syndrome. Earlier, there were a lot of controversy that Miller-Fisher, the site of lesion, is brainstem and not peripheral nerve.
Yes, ma'am, you have proved that that GQ1 antibody is positive in this particular child. Otherwise, in the absence of that testing, we will be giving a provisional diagnosis of Bickerstaff and treat accordingly. But since you have proved, it is very useful that it is a confirmed case of GQ1B antibody syndrome. Congrats.
Yes, ma'am. Yes, absolutely. Otherwise you would be shooting in the dark and not knowing what we are treating. Yeah.
At least we now know confirmed by with the evidence we are treating with this as a Bickerstaff.
Yes. Yes, go ahead, Dr. Sangeeta.
Yeah. Hasan, please start your presentation.
Good morning, everyone. So second case is of Master Y. He presented to us at 3 years and 11 months old, 11 months of age. He's a boy from Erode, Tamil Nadu, and he's a firstborn to non-consanguineous parents. Presented to us with complaints of seizures since 3 years and 4 months of age, and weakness of right upper and lower limb since 3 years and 6 months of age. The antenatal history was uneventful, and he was a full term delivered by a cesarean section with a birth weight of 2.56 kg, and the neonatal history was unremarkable. He attained all age appropriate milestones, and premorbidly he could write tricycle, copy circles, speak in sentences, and was dry by day. So he presented at 3 years and 4 months of age with the first episode of unprovoked seizure which was characterized by right eyelid blinking followed by clonic movements of right upper limb with preserved awareness. It lasted for around 15 minutes. He was evaluated elsewhere with EEG and MRI, which were reported to be normal. And thereafter, he was treated with levetiracetam, and his seizure frequency remained to be 1 to 2 per week. 1 month after that, the seizure frequency gradually increased to 1 to 2 per day, and all the seizures were like 2 to 5 minutes duration. Some of them were preceded by with an aura of fear, and child would cling to the mother during that event. 2 months into the illness, the seizure frequency gradually increased to 3 to 4 per day, and mother noticed there was a paucity of movements of right upper and lower limb, so that he could not lift his arms above his head. At around 3 years and 11 months of age, he developed an acute febrile illness, and after 2 days after that, the seizure frequency increased to 8 to 10 episodes per day with a similar symbology, and each episode lasted for around 1 to 2 minutes. And he was admitted elsewhere and evaluated with the autoimmune encephalitis panel and NMOSD panel. Both of them were negative, and he was treated with pulse dose of methylprednisolone and other anti-epileptics like oxcarbazepine, levetiracetam, and clobazam. In spite of this management, he continued to have daily seizures of around 15 to 20 episodes. There is a positive family history in paternal grandmother since middle age, and she is on anti-seizure medications. Based on the history of right focal motor seizure with right hemiparesis, we would localize to the left frontal lobe in the motor cortex area.
What happened to the language?
Ma'am, the language was normal. Speech was normal at that time.
Speech was normal. No, after seizures, after so many seizures, he
Yes,
tend to
ma'am.
have very frequent seizures, and
Yes, ma'am.
even after that, the language functions were not impaired.
Yes, ma'am.
There was no regression in the milestones.
There were no regressions in the milestone, ma'am. Only paucity of the right upper
Facial
and lower
weakness.
limb. Facial weakness was noted, ma'am, later.
Now, Dr. Sangeeta, do you want people to comment on this clinically and this history? Would people like to consider Rasmussen encephalitis?
Yeah, I just had a question, sir, Professor GK, sir. See, you mentioned about autoimmune panel. That did it indicate? Did it include glutamate receptors also? I'm asking the presenter, Fasil.
Yes, yes, sir. We have evaluated later, sir. During
But
admission,
in the
it
initial
included.
one, you did not have.
In
It
the
was not
initial,
done.
no, sir, it was not done there.
Okay, thank you.
So the autoimmune encephalitis panel actually doesn't include the glutamate receptor, actually, the ones which we do.
Okay, ma'am.
Yeah.
Because specifically, that is what we would like to have here.
Would you clinically call it as a Rasmussen encephalitis before you
Yes,
go
sir.
to antibodies?
I would call it as a Rasmussen's, and that's why I asked for a auto antibodies to glutamate receptor.
Right.
Blue GR.
Right.
That's my.
The second
There are
thing
others
would be-
there. So many are there. You can ask them.
And second thing, probably I would like to repeat a good quality MRI to make sure I don't miss focal lesions or cortical dysplasia. This could have been missed by the earlier CT scan. But those things do not have a progressive hemiparesis. So probably Rasmussen would be the first diagnosis clinically before we go to antibodies.
Yes, sir. We consider the differentials
Thank you
of
for
Rasmussen encephalitis, and of course, we also consider a possibility of MELAS as well, because this child had worsening with intercurrent illness. There was progression of hemiparesis, as well as he had a flurry of seizures after an intercurrent illness. MELAS was also one other differential we considered. Yes, proceed, Fazil.
So on examination, child was awake and alert. Weight, length, and head circumference were appropriate for age. There was no dysmorphism seen, and there were no neurocutaneous markers.
Right.
Uh,
That male should be a little more intermittent, isn't it? Recovered as a more dark spiral. Maybe you are right.
yes, sir. Then in higher function, he was interacting with parents, obeying simple commands. He had left hand preference, and the speech was normal. There were no cranial nerve palsies, and on motor examination, the tone of the right upper and lower limb was slightly reduced, and there was the power of the right upper limb and lower limb was 3/5. However, the reflexes were normal. So this is the video at the time of presentation when he has the right side twitching of the eyes and face with right upper limb clonic movements. So to summarize, he's a 4-year-old boy with a typically normal development, had superrefractory right focal status epilepticus, and had followed by right hemiparesis. So differentials we considered were Rasmussen encephalitis, then HHE syndrome, and MELAS. Then on investigations, the screening for IEMs were negative, vasculitis panel were negative. Then
Go ahead, Vasil, please go ahead.
Then onconeuronal antibodies and other GAD antibody were also negative. CSF analysis was done, which was unremarkable in that the cytospin revealed no abnormal cells, and CSF lactate was also done in view of MELAS, and that was normal. Cultures, TB workup, and then anti-measles antibodies and other autoimmune encephalitis panel all were negative. So the MRI done, it revealed gyral swelling and T2 signal changes, hyperintensities in the left frontal lobe, and which had diffusion restriction in the same areas. And however, there was no cortical atrophy seen or any caudate or putaminal signal changes. The EEG done at that time revealed epilepsy.
Was there contrast enhancement?
No, ma'am, there was no contrast enhancement at that time.
Yeah. So we can see a significant gyral swelling, isn't it? Yeah.
Yes, there was gyral swelling and T2 and flare.
This was at the time of admission.
Yes, ma'am.
And he had a prior MRI which was reported as normal. Huh?
Yes, ma'am.
It was reported as normal, but we reviewed back the images. The same area was involved in the outside MRI as well, ma'am.
Please go ahead.
Then EEG done at that time when child was admitted in ICU, it revealed a epileptiform activity arising from the left hemisphere, predominantly left frontal, central, and parietal areas. Then during the first week of admission, he was treated with the loading dose of levetiracetam and lacosamide. But in view of persisting seizures, he was initiated with midazolam infusion, and then he was shifted to PICU. He continued to develop multiple episodes of seizures of similar semiology. Because of the increasing dose of midazolam, he was electively intubated and mechanically ventilated. And later, IVIG was started, 2 gram per kg over 5 days, followed by pulse dose of methylprednisolone, 30 mg per kg per day for 5 days, followed by oral tapering dose of steroids. Multiple anti-epileptic agents were used, including valproate, lacosamide, clobazam, brivaracetam, phenobarbital, pyrampanel, and topiramate. Midazolam was titrated to a maximum of 10 microgram per kg per minute, and ketamine to a maximum of 5 mg per kg per hour. Even then, the seizures continued to occur. We planned to give rituximab, but in view of fever and hypertension, it was deferred and antibiotics were escalated. He also developed hyperammonemia during the hospital stay, and it was treated with carnitine and sodium benzoate. Seizure frequency were 10 to 15 episodes daily in spite of midazolam and ketamine infusions. Phenobarbital coma was also induced. EEG revealed.
There is a question. Fasil, there is a question whether all the anti-seizure medications were used simultaneously or sequentially.
These were used sequentially, but when there was no response, we did not taper any of the previous medication.
Yeah, the child was managed as per the status epilepticus protocol. He was managed with sequential loading of anti-seizure medications followed by the maintenance. And then since the seizures were not controlled, he was started on midas infusion. Since shock was a problem, ketamine infusion was also added up. Proceed.
Later, EEG revealed electrographic seizures, and there was no improvement in clinical seizures. We planned for an emergency epilepsy surgery. So, in view of superrefractory right focal status epilepticus and right hemiparesis, and MRI and EEG correlating to the left hemispheric disease, a possibility of epilepsy with structural etiology, probably Rasmussen's encephalitis, was considered, and emergency epilepsy surgery was considered. So, during the 5th week into the admission, left peninsular hemispherotomy was done, and post-surgery, he was seizure-free, and the EEG repeated showed no epileptiform discharges. However, some left hemispheric dysfunction was seen. Injection midazolam and ketamine were gradually tapered and then stopped. In view of prolonged ventilation, he also underwent tracheostomy, and mechanical ventilation was gradually weaned off. And by the end of 7th week, he gradually regained sensorium and could recognize and interact with mother, predominantly with gestures. However, he could make sounds but could not vocalize. But comprehension was intact, and he could communicate with gestures. He was initiated on oral feeds, which he was tolerating well, and then he was discharged on tracheostomy, which was planned to be removed later. So this was the CT scan done later, post-operative, where we can see the left hemispherotomy done. The brain biopsy revealed cortical atrophy with neuronal loss and reactive gliosis. I'll acknowledge the neurosurgery team, the PICU team, and the neurophysiology team.
So what was the final diagnosis?
So, ma'am, we kept it as a Rasmussen encephalitis.
So it was a superrefractory focal status epilepticus due to an underlying structural etiology. That's a Rasmussen encephalitis. Yeah, proceed.
Does the biopsy finding go with that?
Biopsy finding, yes, sir. We didn't have the typical findings of what we get in the Rasmussen encephalitis. There were no like lymphocytic infiltrates. So it just revealed an atrophy with neuronal loss and reactive gliosis. It's not the typical finding which we get in the acute phase of Rasmussen encephalitis.
Again, it's probably because this was like a catastrophic presentation of Rasmussen's. So, usually we see all these changes in long-standing. Yeah, probably because of that.
Madam, there is no evidence of Rasmussen at all in this case, either by the immunological test nor by the biopsy. Probably there is a structural lesion inside, which is probably even after biopsy we have not identified. That is more possible rather than Rasmussen.
We even considered focal cortical dysplasia, sir, but when we repeated the imaging before taking up for the surgery, there was a progressive cortical atrophy of the left hemisphere. In clinically also he had progressive hemiparesis as well. Clinically as well as radiologically he was fulfilling. And the antibody testing autoimmune encephalitis panel done from here doesn't include the glutamate receptor antibodies. I'm not sure it is being done anywhere else outside. Do you do it in MMC, sir?
No, madam. No, we don't have that.
And
No, I don't think
it has to be done
that's-
outside
yeah.
only.
Yeah,
It has to be done outside.
Okay, sir.
Dr. Sangeeta, it has to be done outside. Probably Amrita may be doing. I'm not sure. They do all the panels. So
Amrita doesn't do the glutamate 5 receptor antibodies. So
Okay.
we have checked earlier for one of our patients. They were not doing at that time.
yeah, GR3
we've
or
had a
GABA
few-
also we might have to do.
We have had a few cases of Rasmussen, but initially probably after opening up and getting the biopsy, you can at least see the perivascular lymphocytic infiltration or features of inflammation inside. So not in favor of inflammatory pathology at all in this case. We have had cases of focal cortical dysplasia removed, but the biopsy was negative, and clinically, and there are papers where focal cortical dysplasia negative suspected cryptogenic focal cortical dysplasias.
Dr. Sangeeta.
So the only
after-
atypical thing for focal cortical dysplasia was one is there was suggestion of a progressive hemiparesis, which wasn't there to begin with, and the meaning if you call it a focal cortical dysplasia, the dysplastic meaning the involvement was rather extensive, and also there was diffusion restriction on the initial MRI.
Dr. Sangeeta,
Yes,
after
It
the
may not be
surgery,
extensive, madam. It may be very focal.
No, the
cortical-
MRI showed quite extensive changes, sir. That's on the neuroimaging showed extensive changes.
sir, I have one question, sir, Dr. Sangeeta.
Please, sir.
See, after the surgery, has the hemiparesis improved or has it worsened or is it static?
So it is after functional hemispherotomy, his power became 0 after the surgery, immediately after the surgery. And he was with us post-operatively for around 4 to 6 weeks, and he was on neuro rehabilitation also. So by the time he was discharged from the ward, his hemiparesis has improved to the power of 2/5. There was no complete recovery. Usually these kids who underwent functional hemispherotomy, we have seen in our experience, at least it takes around 2 years to have a significant improvement in the power.
And no word output.
No, he has, because he was on tracheostomy, the language could not be assessed. Yeah.
Usually, hemispherotomy, the recovery will not be there. Will not be very much very significant. Most of the time, they have permanent hemiplegia.
Usually the proximal power improves, but the distal power kind of still remains quite, meaning quite weak. The distal power, there is still a lot of distal weakness. The proximal power improves to about grade 3.
Yeah, there is improvement. And
Yeah, carry on, Fazil.
I'll discuss in brief about Rasmussen's encephalitis. It was first described by Theodor Rasmussen in 1958. It's a chronic disorder where there is progressive encephalopathy, and it's characterized by unilateral inflammation of the cortex with drug refractory focal epilepsy and hemiparesis. There's also progressive cognitive deterioration. So if we see the stages, the first one is the prodromal stage where there is where there are infrequent seizures with mild hemiparesis, and later in the acute stage there are frequent seizures and may even lead to epilepsy partialis continua. There is progressive hemiparesis and then hemianopia and cognitive deterioration, and if it's a dominant hemisphere, then there might be aphasia also. Later in the residual stage, there is permanent and stable neurological deficit with the motor and cognitive problems along with difficult to treat refractory seizures. So if we see the timeline, initially in the prodromal stage, when the volume of the hemisphere is normal and there is no inflammation, the motor function is normal and the seizures are very infrequent. So as the inflammation sets in, the seizure frequency gradually increases, and then it comes to the peak of epilepsy partialis continua, and then there is cortical atrophy and motor deficit seen. If we come to the treatment approach, the Rasmussen encephalitis, if it's a slow disease progression, then we can give a trial of immunotherapy along with anti-seizure medications. And if there is good response, then we can continue the treatment. However, if there is no response, then we can consider surgery. And in case of rapid disease progression, we can consider early surgery also. The first presentation of Rasmussen encephalitis, if it's a dominant hemisphere with a catastrophic presentation like a status epilepticus, we can consider IV methylprednisolone along with IVIG, followed by a course of rituximab or cyclophosphamide, and then we can plan surgery later. In case of a non-catastrophic presentation where there are frequent seizures, we can give methylprednisolone followed by oral tapering dose and steroid sparing agents like azathioprine and methylphenolate mofetil till the surgery. In case of non-dominant hemispheres, we can plan for an early surgery. So surgery still remains the only cure where the complete disconnection of the affected hemisphere is done either by hemispherectomy or hemispherotomy. The long-term seizure-free outcome is around 70 to 80%, and the timing of surgery can be guided by the severity of the epilepsy. Some studies advocate for early surgery to protect the contralateral normal hemisphere from the repeated seizures that are occurring. The appearance of contralateral EEG abnormalities early in the disease might also highlight and indicate early surgery. Findings of some studies of children undergoing surgery show a short seizure duration and better cognitive outcome, and it suggests that early surgery should be considered to improve these outcomes. Most results show cognitive stabilization after spherotomy, and with better outcome in cases of non-dominant hemisphere surgery. A study by Sanjeev Bhatia from Miami Children's Hospital, they have reported 15 patients who underwent an emergency surgery after refractory focal seizures. The preoperative duration, mean preoperative duration was around 8 weeks, and post-surgery, almost all the patients were seizure-free. Another case series reported by Alexopoulos, in which they had 10 patients in which 2 weeks who failed to recover after 2 weeks of immunotherapy. The epilepsy surgery was done, and 70% of them were seizure-free post-surgery. Thank you.
Thank you, Dr. Sangeeta. Would you probably stress for the other audience that the early evaluation of focal fits, especially refractory, for epileptic surgery is an important take-home message?
Pardon, sir?
Would you like to stress the point for the benefit of all the audience?
Yes.
Early uncontrolled focal fits needs early surgical evaluation. Probably that's one point which we should probably stress to everybody.
Yes, when we identified a structural etiology which is surgically amenable, which is there in the non-eloquent cortex, presenting as a refractory or a super refractory status epilepticus, they should and also having this progressive kind of neurological deficit, they should be considered for early epilepsy surgery. And there is a question in the chat box: is there anything called as super refractory status epilepticus? We haven't come across the term of super refractory status epilepticus. There is super refractory status epilepticus, which means any seizure persisting for more than 24 hours while on anesthetic treatment, or seizures recurring while you're attempting to give anesthetic medications. So if it, I haven't come across this term, Dr. Suresh has mentioned in the chat box. Have you come across this terminology, sir? If so, please share about it.
I think most of us are exhausted by the time we have super refractory state. I don't think we are alive to handle super. Let Dr. Suresh comment.
I think the line of management would be the same.
Quite right.
Yeah. Somebody's asked, what's the cause of
another
gyral
question is-
swelling, Sangeeta?
Yes. So the causes of gyral swelling in this particular case could be related to the cytotoxic edema, or it is because of the acute inflammation in the acute stage of the Rasmussen encephalitis. So other causes of gyral swelling, if you're asking, it could be a focal encephalitis, or it could be in case of metabolic disorders like MELAS or other mitochondrial disorders where you can have gyral swelling. And there is another question, was there any special staining of the brain biopsy specimen? In this particular patient, we haven't done any special staining because we have not considered tumor as a possibility. Even before the surgery was done, the second MRI was showing a progressive volume loss and atrophy. So we haven't considered a tumor as a possibility, so we have not considered any special staining.
Thank you.
Dr. Sangeeta, have you come across cases of Rasmussen with who did not require hemispherectomy, who have been controlled with anti-seizure medications and immunological therapy?
Yes, this child was like a hyperacute presentation with the status epilepticus, though even prior to that, from 3 or 4 months of age, he had hemiparesis and also like a frequent focal motor seizures. But we do see in our office practice children presenting with recurrent focal motor seizures with subtle hemiparesis, and sometimes they present with only movement disorder like hemidystonia, and imaging findings are typical of Rasmussen encephalitis. We don't directly go ahead with the surgery first. So we try on anti-seizure medications, and we give them immunotherapy. We give them IVIG and steroid and rituximab. And if they have a good seizure control, we follow them only with the immunomodulation and the anti-seizure medications. We don't go for surgery early. But there are most of the patients have progressive atrophy, and then they have poorly controlled seizures. They finally land up with epilepsy surgery.
If it is a rituximab, how long rituximab you continue?
So we give 375 milligram per meter square weekly once for 4 weeks. And we follow them with a low dose of steroid. Like initially we start with 2 milligram per kg and taper it over a few weeks and maintain on 0.5 milligram per kg. We don't stop it at the end of 12 weeks. We just tend to maintain them on a small dose, though we give us like a steroid sparing agent like rituximab. So at the end of 6 months, if the child is having a good seizure control, we just maintain on low dose steroid for 2 years. And if the child is having a recurrence of seizures or poorly controlled seizures, we consider an early surgery rather than keeping up on cycles of rituximab every 6 months.
Okay, thank you.
We don't have facilities for neurosurgery or epilepsy surgery, but we have managed Rasmussen encephalitis only with recurrent anticonvulsants for a long time. And slowly it burns off, the cortical atrophy sets in, and seizures may come on and off. Surgery is not. The rituximab is usually, we have not tried in children, mainly because the seizure in these children, the cognitive impairment is not at all seen, or in the sense that speech is not at all affected, which is a very significant part which we see in autoimmune encephalitis. If we don't get cognitive impairment, we strongly doubt the diagnosis of autoimmune encephalitis. That too,
I think he rightly pointed out the catastrophic presentation and non-catastrophic presentation. I think most of us are now asking interested more about the non-catastrophic presentation, which you have managed, which you and Dr. Megandan has outlined it. There is one more question.
Ramakrishnan sir has asked whether there is any role for tacrolimus in the management of children with Rasmussen encephalitis. Though the literature reports use of tacrolimus, we have no experience in using it. In those children who have a good seizure control, or like where we just consider an alternate immunomodulation instead of rituximab, we tend to keep them on azathioprine or mycophenolate depending upon their affordability. Ramakrishnan sir, do you have any experience with using tacrolimus? You can share with us.
Yes, Dr. Sangeeta. I have two patients whom I have started them on tacrolimus because literature what I have gone through, they say it's more of a T cell mediated disease process where they will respond well to tacrolimus. So I have kept two of them on tacrolimus and seizures seems to be under control.
Okay, sir. Okay. Thank you, sir. Can we move on to the next patient, sir?
Please.
Yes, I think we
Thank you
should
for a
move
good.
on. Yeah.
Thank you, Faisal, for a good presentation.
Thank you.
Thank you, sir.
Thank you.
We'll have the next presentation by Dr. Abhinaya, who is also DM resident in our unit. Go ahead, Abhinaya. Thank you.
Good afternoon, everyone. Am I audible?
Yeah, you're audible.
Yes,
And
So today, I'll be discussing about a case of two siblings who presented to us in May 2018. This is the eldest sibling, Master A, who presented to us at 7 years and 7 months of age with complaints of outward deviation of the right eye and reduced hearing in bilateral ears noticed since 7 years of age. So in November 2017, there was history of intermittent outward deviation of the right eye. Around 3 to 4 weeks later, he also developed reduced hearing in bilateral ears, and he used to respond only when spoken loudly. At the same time, he had some history and difficulty also. He was unable to write within the lines of a book, and his handwriting used to go up and down. Mother also noticed some generalized skin hyperpigmentation of the boy. For these complaints, he was evaluated elsewhere with imaging, hearing evaluation, and blood investigations. Following which, just 3 to 4 weeks prior to coming to CMC, he also developed gait imbalance and some difficulty in walking. There was no history of any seizures, sleep, or behavioral disturbances. There was no history of any cranial nerve involvement, no speech disturbances, no stiffness or floppiness in limb, no difficulty in climbing stairs, raising from squatting position, or raising arms above the shoulder. There was no history of difficulty in holding the pen, mixing food, wearing buttons, or gripping slippers. There were no tremors or incoordination while reaching the objects or swaying. There were no abnormal twisting postures in the limbs. There were no sensory or bowel bladder disturbances. His antenatal perinatal period was normal. He had some respiratory distress at birth and was kept in the NICU for 2 days and developed jaundice, for which he received phototherapy. Otherwise, he was a premorbidly normally developing child, was placed in the 3rd standard and was securing A+ grade even after the writing difficulty had commenced. Coming to the family history, there was significant family history on the maternal side. 3 of the mother's first cousins, all males, had similar complaints which started between the age of 7 to 12 years. And 2 of them succumbed at 20 to 25 years. And another cousin succumbed at 33 years of age. The younger sibling was also screened and found to have the same problem. On examination at presentation, he was alert, right-handed. He was only responding to repetitive commands because of his hearing difficulty. Hyperpigmented knuckles and gums were noticed. His anthropometric variables were within normal limits. This is the clinical picture. At presentation, we can see the striking difference in the skin complexion between the elder sibling and the younger sibling. So this generalized hyperpigmentation was also one of the complaints with which the parents had brought the child with. On examination, the higher mental functions were normal. On cranial nerve examination, the bilateral pupils were equal in size and reactive, and visual acuity by 6/18 in both eyes. And there was bilateral temporal pallor which was observed. There was a non-paralytic right divergent squint. Otherwise, the rest of the cranial nerve examination was normal. On motor examination, the bulk tone was normal and power was 5/5 in all limbs, and the DTRs were 1+. There was mild gait ataxia noted. However, there was no dysmetria, dysdiadokinesia in the upper limbs. The skull and spine was normal. The systemic examination was also within normal limits. So we have a 7.5-year-old male who was premorbidly well, presented with insidious onset progressive visual and hearing impairment with gait imbalance and significant similar history in multiple male members of the family. And on examination, there was optic disc pallor, hyporeflexia, and mild gait ataxia. So the neuroanatomical localization was kept to the optic pathway, the auditory pathway, and probably the cerebellum and its connections, and because of the hyporeflexia, the peripheral nerves. However, looking at the case as a whole, based on the clinical history examination and also the significant family history, the first possibility we thought was of a white matter degenerative disease, probably an X-linked neurodegenerative disease. And the most common would be the X-linked adrenoleukodystrophy. The other possibilities considered down the line were probably a juvenile onset Krabbe's, a metachromatic leukodystrophy, or even a mitochondrial cytopathy. On evaluation, this was.
Do you want people to comment? Sorry, 1 minute. Do you want people to comment?
Yeah, any comments? Here, of course, the diagnosis was rather straightforward because of significant family history, skin hyperpigmentation, and the sort of, auditory and visual impairment. Yeah, any comments?
Was there any cognitive decline, madam?
No, ma'am.
Or behavioral disturbances?
No, ma'am. No sleep, behavioral disturbances, or cognitive decline. He was doing very well before coming here. Even the last exam also, it scored A+ just before coming to our.
Now, to me, sorry, Megan, carry on.
Normal long track signs, madam, with no spasticity, brisk reflex are normal.
Yes, sir. And presentation, no long track signs were elicitable.
That is something unusual in this case, because we first thing we will see will be the pyramidal signs with brisk reflexes. Then only the pigmentation starts and the cognitive decline starts. That is the usual presentation. Maybe different, maybe an atypical presentation.
Maybe the adrenoleukodystrophy presenting first as deafness, as a presenting complaint, looks a little abnormal, looks a little unusual. I would probably think about those inherited, probably autosomal or cerebellar degeneration with the deafness and visual variety of syndromes. I cannot recall those syndromes. And the hypopigmentation doesn't bring in metabolic conditions like B12 dependent diseases. I'm not offhand able to name them. The hypopigmentation, family history, autosomal. Am I still dealing with some metabolic disease in which vitamin B12 is involved? It's what's a wide guess.
Yes, hyperhomocystinemia could also be considered, but the pattern of inheritance would be autosomal recessive. Here, there is a clear pattern of X-linked inheritance. And so we consider X-linked adrenoleukodystrophy as one of the first differential rather than B12 metabolism disorders. Of course, as Sir said, like hyperpigmentation of knuckles and gums, any treatable hyperhomocystinemia would be the other differential if there is no definite family history.
Thank you. Carry on, please.
Carry on, Abhinaya.
So this was the MRI which was done elsewhere in March 2018, 3 months prior to visiting us. So this shows the characteristic bilateral symmetrical T2-weighted hyperintensities in the posterior parieto-occipital white matter, deep white matter, involving the subcortical regions and also the splenium of the corpus callosum. There is also diffusion restriction which is seen, and this is the characteristic serpiginous garland-like enhancement of the active demyelinating edge which is seen on a post-contrast film. So the lowest score in this MRI, which is an MRI generated score for children with adrenoleukodystrophy for prognostication, was 10 before presentation. This is the lowest score, which is an MRI severity scale with a minimum of 0 and a maximum of 24. So it includes parieto-occipital white matter, anterior temporal white matter, and frontal white matter changes classified based on the area involved, the corpus callosum and the areas involved, the basal ganglia, the visual pathway, the auditory pathway, and the projection fibers. So this was the MRI which was done elsewhere again, which also shows some pyramidal tract involvement. However, though we did not get any signs clinically, the imaging was definitely showing hyperintensity of the pyramidal tracts. So the neurological function score at examination was 3. This is a clinical assessment score again for prognostication and for further treatment purposes. A score of 0 to 1 usually has good prognostication, and this child, when he presented to us, already had a score of 3. When he came to us in June 2018, a repeat MRI showed similar findings, and the lowest score was 10. His adrenocortical function revealed hypocortisolism, and audiogram revealed bilateral sensory neural hearing loss. In the VEP, we got prolonged P100 latencies. The nerve conduction study and the SSCPs were normal. The VLCP levels revealed elevated C26 lysophosphatidylcholine levels. So he was started on hydrocortisone and on a mustard oil based diet. We went ahead and did the targeted genetic testing. So the sequence analysis of the proband revealed a hemizygous variant in the exon 10 of the ABCD1 gene, which has been previously reported in databases. The younger sibling who was asymptomatic at the presentation was also screened and also found to be hemizygous for the same variation. Master A underwent bone marrow transplantation in August 2018, that is 2 months after presenting to us. It was an allogenic haploidentical transplant. However, even after transplant, there was progressive deterioration in vision.
Who was the donor, Abhinaya?
The mother, ma'am.
Okay.
In August 2018, he had stopped tracking objects. The menace was absent. The hearing was slightly better. He was still walking unassisted. In September 2018, on investigation, the chimerism was complete. Only donor-related peaks were seen in the peripheral smear. On December 2018, that is around 4 months after the transplant, was the last in-person follow-up of the child. At that time, he only had perception of light. The pupils are very sluggishly reacting, and he was still walking. He was ambulant, but he continued to progress clinically. And within 6 months, after the transplant, he's become bedbound. This was the last MRI done in May 2019, which is showing progression. And now there is a involvement of genu of the corpus callosum with diffusion restriction as well. We don't have a post-contrast for this MRI. The Lowy score also has progressed to 18. So this is the current image. The child is now 12 years, 4 months. We can see significant hyperpigmentation over the face. There is a spasticity which has set in. He's bedbound, and there's visual and hearing impairment.
What about the sibling, dear?
Yes, ma'am. I'm presenting the sibling.
Yeah, she's going on. It's now the story is not finished.
Yeah.
So when the index case came as well, we screened the younger sibling at the same time. He was asymptomatic with no significant antenatal perinatal risk factors. So his examination was also within normal limits. Anthropometry was also within normal limits. So his genetic testing, as shown prior, had also revealed the same hemizygous variant. His VLCFA also was significantly elevated. The cutoff is for a postnatal child is 0.06 to 0.51 per 1/8 of the inch spot, whereas for master N, it was 1.19 picomole per 1/8 of inch spot. We had kept him on close follow-up since he was asymptomatic clinically, and the initial MRI was normal. And his initial evaluation for adrenal function was also normal. So a repeat MRI in October was also normal. In March 2019, we started to see early MRI changes. There was very subtle hyperintensity seen in the splenium of the corpus callosum. And early signs of adrenal failure was seen in the ACTH stimulation test. So he was started on hydrocortisone. His neurological function score was 0. We again repeated an MRI in December, which showed progression in the child findings. There were no clinical symptoms. His NFOs continued to remain 0. He was continued on hydrocortisone. So this is the MRI of March 2019, which showed very subtle hyperintensity, whereas in December 2019, the hyperintensity is progressed to involve almost the entire splenium of the corpus callosum. So he underwent haploidentical stem cell transplant with the father on 18th of January 2020. And this is the MRI 6 months post-transplant. We can see the restriction of the deficient restriction as well as the hyperintensity is still restricted to the splenium of the corpus callosum. And the child also is still asymptomatic with no clinical signs, visual or hearing impairment. 3 months after the transplant, he developed lichenoid graft versus host disease. He was started on treatment. He continued to remain neurologically and radiologically stable. In August 2020, that is 7 months after the transplant, we repeated the VLCFA. So the baseline one was 1.19, and we can see there's a 50% reduction in the VLCFA levels. It is just marginally above the upper limit of the normal level. By July 2021, he was off all immunosuppressants, and his MRA brain continued to remain stable with no progression of changes. So these are the subsequent MRI brains. This is in July 2021, Feb 2022, and this is the latest MRI, July 2022, which all shows involvement and some atrophy of the splenium of corpus callosum. Presently, the child is doing well in class 4, has an above average scholastic performance. There are no vision, hearing, or gait problems, and there is no significant progression in the neuroimaging.
Any comments?
Any electrophysiological studies, madam, for the younger sibling? Because VEP prolongation or BERA formation.
So all our adrenoleukodystrophies prior to BMT, they have the full gamut of neuroelectrophysiology in the form of nerve conduction study, VEP, BAR, and SSEP, tibial and medial. And this one was these were all normal in the second child. It was clinically also normal. And
second child MRI is definitely showing changes, madam. So probably we have to follow him up to say the prognosis. We don't get, what about the hearing, madam? The hearing was completely gone in for the first child. What about this child, ma'am? This child hearing assessment should be little more.
Hearing assessment was done. That is what was mentioned. The neurological function score was 0, and both the audiometry as well as the brainstem auditory work responses were also normal, and has remained normal. The thing is, when they don't have MRI changes, around 50 to 60% of them go on to develop, go on to remain with no brain involvement. So with no evidence of MRI involvement, you cannot actually take them through BMT, because it is known that around 50 to 60% of them will remain without any brain progression. So with the earliest involvement of the brain, that's when you kind of, take them for BMT. So though we did see the initial splenial changes in March 2019, it did not show any diffusion restriction or contrast enhancement. So that is why repeat MRI, with the repeat MRI, we kind of took him through BMT.
There's a question in the chat box.
Sorry, what was that?
Is there any difference between the mother and the father as a donor?
The mother would probably be a carrier, sir, because both her sons are affected, and there is significant family history on the maternal side of her first cousins being affected. Though the mother has not been tested genetically for the carrier status, but it's
Sangeeta, do you want to give, give your
yes.
comment on
Yes.
a heterozygous mother? And, normal father
so we
being
have
the donor?
since we have been regularly doing bone marrow transplants in children with ALD and metachromatic leukodystrophies, so we have done a literature review on this earlier. If you look at ALD, the pattern of inheritance is X-linked. So mother will be a donor, carrier in most of the patients. Like we test the VLCFA level in the mother, or sometimes we go ahead with the genetic testing as well. Ideally, if you see, the donor carrier is not the best carrier. The carrier mother is not the best donor. So we have to go for a donor who is a non-carrier. But at all practical purposes, if you start looking for a carrier, non-carrier donor in the unrelated registry, so it takes a longer time to get a unrelated donor who has got a best HLA match. So we go ahead with the transplant with the mother or the father who has the best HLA match. Even though the mother is a carrier, we would prefer to take the mother or sister as the donor. But for the other disorder like metachromatic leukodystrophy, if either of the parents or carrier, and if they have a best HLA match, again we go ahead with the parents as the donor rather than going ahead with the search of a unrelated donor, because that will be very expensive and it will be time consuming, and we will lose the golden time for the transplant. The children might progress in terms of clinical deterioration as well as the radiological deterioration, which might adversely affect the long-term neurocognitive outcome as well as the survival rate. So even though the mother is a carrier, it is not a contraindication to take the mother as a donor for the transplant.
There is a question asking why not the father as a donor in the first child? Possibly yes, but in both the children, the HLA matching with the father was less than that was for the mother. So that is why the mother was opted for in the first case, and in the second case, because of this heterozygosity in the mother, we took the father. So far, he's remained okay, the child. Go ahead, Abhinaya. You want to carry on with the rest of the presentation?
Yes, would like to offer my sincere thanks to our departments of hematology as well as radiological sciences for their contribution. Coming to X-linked adrenoleukodystrophy, it's the most common paroxysmal disorder. The incidence has been reported to be between 1 in 20,000 to 1 in 50,000 newborns. The mutation is in the ABCD1 gene, which is located in the X chromosome. This mutation causes absence or dysfunction in the ALDP protein, which is a peroxisomal transmembrane protein that transports the VLCFA acyl-CoA esters from the cytosol into the peroxisome, where they undergo the beta oxidation. So this transport is affected, and hence this beta oxidation of the VLCFA coesters don't occur. So there is abnormal accumulation of the VLCFA. This accumulates in the plasma, the white matter of the brain, the spinal cord, and the adrenal cortex, hence responsible for the clinical symptoms. So this is the pictorial representation of the same. The ALDP protein when ABCD gene when mutated, this protein is not functioning. So there's no transport of the VLCFA into the peroxisome. Hence the degradation cannot occur. So there's abnormal accumulation of the VLCFA. Coming to the clinical presentation in males, it can vary from childhood cerebral phenotype to an adolescent presentation, an adrenomyeloneuropathy presentation, an adult onset presentation, oligopontocerebellar presentation, an Addisonian disease only, or they could be asymptomatic. So the most common one, which is amenable for treatment, is the childhood cerebral phenotype, where there is progressive neurodegenerative decline, which leads to a vegetative state without immediate treatment. So the onset is usually in the first decade, and this is the most frequent type encountered. The other phenotypes are much less. The adult onset ones will present more with neuropathy paraparesis, and they present mostly in the second or third decade. So coming to the diagnosis, based on clinical suspicion, we can go ahead and do the VLCFA levels. So the three VLCFA parameters which we assess are the absolute level of the C26, the ratio of the C26 to C22, and C26 to C24. If this is elevated, we can do a targeted testing of the ABCD1 gene. And even a newborn screening has been started in many countries for early intervention and to prevent the devastating consequences of the cerebral adrenoleukodystrophy. Subsequent analysis of the adrenal function also has to be done for starting the symptomatic management. So the management is primarily symptomatic with diet restriction with Lorenzo's oil, or in Indian scenarios, we can offer mustard oil based diet. Immunosuppression has not shown any significant benefit. So the treatment options are targeted to specific phenotypes. So the phenotype which we'll be discussing is the cerebral onset, cerebral adrenal leukodystrophy. So for that, hematopoietic stem cell transplant is the treatment of choice, and to treat adrenal insufficiency associated with it. So this is a recent guidelines which has been published regarding the screening and follow-up of children with different phenotypes of ALD. So a child with cerebral ALD, a baseline MRI should be done. And the screening protocol is, if the MRI is normal at baseline, between 2 to 12 years of age, where most of them will progress fast, an MRI should be repeated every 6 months. And if they have not progressed significantly till 12 years of age, we can reduce the screening to an annual screening. And the treatment is either hematopoietic stem cell therapy or gene therapy. So for the other, adrenal insufficiency also has to be evaluated at presentation. And then every 3 to 6 months till 10 years of age, the screening should be continued. And we have to adequately supplement with hydrocortisone. So the rationale of hematopoietic stem cell transplant is to reestablish the blood-brain barrier integrity by intense immunomodulation. And the accumulated VLCFA are known to cause oxidative stress and hence lead to demyelination. So the bone marrow transplant is known to decrease this oxidative stress. And it also reduces the increased VLCFA concentration by providing a competent beta oxidation, because the normal cells transplanted will have the functional enzyme. So the functional donor cells will cross the blood-brain barrier and exert favorable effects on the mechanisms which lead to demyelination. So post-transplant, the resolution of contrast enhancement is a common feature of successful transplant. So the recommendations according to the recent guidelines is the transplantation eligibility should be determined by an ELD transplantation expert. So the eligibility criteria is not exclusive. So in general, the boys are considered eligible for transplantation when they have a demyelination with contrast enhancement, and the MRI severity score should ideally be less than 9, and a neurological function score should be 0 or 1. And in adult men, they can have demyelinating lesions with enhancement with or without minimal neurocognitive impairment. So this is in brief regarding the screening. So at presentation, we do the neurological, psychological and magnetic resonance imaging. So if it is a normal, if all are normal, we just follow up the child every 6 months till they are 12 years of age. There are characteristic changes on the MRI, then we evaluate for signs for progressive disease. That is, either they have clinical symptoms or they start developing cognitive symptoms. There is a worsening of the lowest score on follow-up. There is contrast enhancement in the lesions, or the MRS is showing an elevated choline to NAA peak. Even if there's no sign, we can continue to screen the child every 6 months. Or we can also do a short term every 2 to 3 months. If there is any more than 2 signs, and there are signs of advanced cerebral disease, such as Lowey score is more than 10, or there's marked cognitive dysfunction and severe neurological symptoms, then ideally stem cell transplant is not recommended. So this is a study published in 2019, where 72 children who were not treated and 55 children who underwent hematopoietic stem cell transplant were compared. This was done among 5 clinical sites. So the Kaplan-Meier survival analysis showed that the 5-year survival for an untreated group was only 55%, whereas for the treated group it was 78%. Other significant observations were 2-year survival without major functional disability. So this survival included children with disability as well as without disability. So without a major functional disability in the untreated group was only 39%. Whereas in the children with an NFS score of 1 and a Lowey score of less than 1, the 2-year major functional disability free survival was almost 84%. The mortality rates were 8% at 100 days and 18% at 1 year. The most common causes of death was either to a primary disease progression or an infection after post-transplant. The most common adverse effects reported post the transplant were infection and acute grade 2 to 4 graft versus host disease and chronic GVHD. And 18% of them experienced engraftment failure after their first transplant. In brief, the predictors of outcome which has been observed after hematopoietic stem cell transplant are, so the patients who have a lowest score of less than 9 have shown a better outcome. Those who have a neurological function score between 0 to 1 have better outcome compared to a high NFS. Also, the later age of onset of symptoms. Suppose a child is presenting to us who has onsets before 5 to 6 years versus a child who presents a later onset. So the child who has a later onset after maybe in the late part of the first decade or early second decade also has better prognosis. The pre-evaluation MRI showing high choline to Na levels also has a poorer prognosis. Non-enhancing lesions have comparatively favorable outcomes, and a matched donor transplant rather than an unrelated donor transplant, who's preferably not a carrier, also has good outcomes. So the take-home message would be to screen the asymptomatic siblings of children who have diagnosed with X-linked ALD. We should go ahead and screen those children with MRI brain every 6 months or early signs of cerebral ALD, because the detection in these MRI abnormalities will precede any detectable cognitive dysfunction by at least 6 months to 1 year. And an allogenic bone marrow transplant should be offered as soon as MRI brain abnormalities typical of cerebral ALD are detected. After successful transplant, the lesions on MRI stabilize and are known to even regress. Thank you.
There are questions in the chat box.
Thank you, Abhinaya. Yeah, one of the question is what is Lorenzo oil? What is that? What does it contain? Basically, it is glycerol trioleate and glycerol trierosate. So the Lorenzo oil is very expensive, and one 500 ml bottle is comes to around 20,000 rupees, and the dosage is 25 ml per day. But we tend to use mainly a mustard oil and olive oil based diet, which seems to kind of help in the asymptomatic children. The other question is peroxisomal biogenesis meaning Zellweger the same as ALD? They all fall in the same spectrum of peroxisomal disorders. Zellweger is the severe end of the spectrum, where you have it's a peroxisomal biogenesis disorder. So they tend to manifest very early in life, whereas the ALD, they present in early childhood, say after 3 years of age. And of course, Zellweger, they have multi-system involvement also. They have got cerebral malformations, hepatic involvement, severe neurodegeneration. Any other comments?
There's one more question. There is one more question, Dr. Maya.
Yes, sir.
There is one more question.
For low score more than 10 but NFS 0, should we go for transplant or not? So we take, even if you could potentially try transplant, but generally the outcome is not good, because usually when you have a low score of more than 10, though the NFS is 0, generally they will have subclinical involvement, in the sense if you do neuroelectrophysiology in these children, they will have involvement of the BAR or the VEP or the SSEPs, in which case, though it is not mentioned in the NFS, they tend to have not so good an outcome.
Madam, for the index
it's only a comment, madam.
This hematopoietic stem cell transplantation
Zoom class
in index children, that is when they come to us itself, they tend to have a lot of neurological involvement with MRI findings. So whether it has arrested the further progression, in your experience, you might have done for a lot of children for ALD. Of course, for the asymptomatic child, we have to closely watch, and whenever they show this MRI, and it will be useful for the sibling. But for the index children,
so in the beginning, actually, we, like you said, we have actually taken up children who were who had deficits and who had significant low score. You give them the benefit of doubt. But what we've seen is these children, once the progression starts, it's a relentless progression. They don't arrest.
In this particular child as well, The children, the
Yeah,
child has
exactly.
become
As you
now
have seen in that
bedbound.
older sibling. Yes.
Yeah.
So once the progression starts, there's nothing which can actually stop that progression. Even though the graft actually, the engraftment is good, the progression is relentless.
Relentless, yeah.
It's a comment, madam. Congratulations.
Yes, sir.
It's a really, congratulations to the Vellore team. I think the whole team which is sitting here should appreciate the bone marrow transplant, which is red only. Previously,
Yeah, I think we have a very good hematology team to support us.
Fantastic, madam.
Yeah.
I'm really thrilled because when we diagnose adrenoleukodystrophy, it's a death sentence previously. Yeah, and hence the whole family will be affected. That is what we have seen. We have seen family crying, and you have definitely made them, at least you have shown them some hope for the treatment, and there's a definite light in the end of the tunnel. And excellent work you have done, madam. It's really excellent. Congratulations.
Thank you, sir.
Thank you. Now, thank you very much. We'll go to that. I think we are running short.
We have one last case, so we have just, I think,
right.
another 15 minutes.
Take it up,
so
we don't want to
we will
miss
have
it.
yes, sir. We'll have a quick
Please.
presentation, last quick presentation. Yeah.
Please.
We have Dr. David to present the final case of the session. He is our second year fellow in pediatric neurology. He is presenting a child with unusual cause of paraparesis. Dr. David, please start your presentation.
Good afternoon, everyone. I'm here to discuss one of interesting case that we came across in our clinics. So this is Miss S, a 15-year-old adolescent girl from Bihar. She had a normal antenatal and an uneventful perinatal history. She had attained all her developmental milestones adequately. She was studied till class 5, but she had some poor scholastic abilities in the schooling. The complaints that she was brought to us are weakness in the bilateral lower limbs. The onset was at 13 years of age, and also the history of diminishing vision, and also increased frequency of urination that was noticed around 14 years of age. So this is the 3-generation family pedigree chart, where the parents are third degree consanguineous, married parents. She's the eldest of the 5 children, and she's affected, and there are 2 affected other younger brothers with poor cognition in one, and one of the brothers was operated for bilateral cataracts around 6 years of age. So this is the timeline of her history. She was normally developing with some poor scholastic skills till 13 years of age. Her complaint started around 13 years of age, where she started having a lower limb weakness, which was a little asymmetric on presentation, left more than right, and then distal involvement more than proximal. It was an insidious onset, and it was gradually progression. By the next year, she had upper limb weakness, and which is also slightly asymmetric on presentation, right more than left, and proximal involved more than distal. Along with that, she had complaints of gradual diminution of vision, and also urinary complaints in the form of urge incontinence, hesitancy, and incomplete feeling of incomplete voiding, and also nocturia. Subsequently, subsequently our lower limb weakness was progressive, and she started developing the bilateral lower limbs. She also developed contractures. Subsequently she became non-ambulant. She was not able to walk anymore without support, with support as well, and she was developing bed sores, and she had a urinary tract infection because she was catheterized outside because of the urinary complaints. At presentation, she's almost 15 years and 10 months, and she's already underwent some investigations before coming here. So there was no history of difficulty in gripping objects in the upper limbs. There's no history of loss of consciousness anytime, no seizures, no cognitive decline, or no behavioral changes. There's no history of restricted eye movements, squints, diplopia, hearing disturbances, or deviation of angle of mouth, or any of the other cranial nerve involvement. There's no history of unsteadiness of gait or activities, no tremors, slurring of speech, or any other involuntary movements. There's no history of sensory loss in the clinical history, no band-like sensation, tingling, or numbness. Earlier in the past, she had a history of joint pains where she was treated with monthly penicillin injections for 3 years, at 8 years, and also he underwent cholecystectomy for cholecystitis at 14 years of age. So in examination, she was slightly below her age-appropriate sentence for age, weight, and length. There was vitals were normal. There were some pressure sores which were represented on the body examination in the form of decubitus ulcers and also healed ulcers on the pressure areas. Some pedal edema was noted, and however, she did not have any facial dysmorphism or neurocutaneous markers. In neurological examination, there were high mental functions were normal, and then there is a visual acuity, diminished visual acuity in bilateral eyes. This was tested with a Rosenbaum chart. It was 2/200 in the right eye, and left eye was 2/100. Color vision was there, and her pupils were equal and bilateral near to the light. However, her fundus showed bilateral disc pallor. Other cranial nerve examination was normal. Yes.
Can show the video from the source.
Yes, ma'am.
David, if it's a problem, it's okay. You can. What we are seeing is the significant wasting as well, isn't it?
Yeah. Yes, ma'am. Pasting and contractures.
Yeah. Okay, you can proceed to the next slide because we are running short of time.
Yes, ma'am. This. Okay. Pose.
You proceed with your presentation. No need to show the video.
Yeah. Sure, ma'am. So this. There's some technical problem.
And as he's trying at the slides, what did you start the clinical discussion? Here is a child with spastic paraplegia, with 4 other siblings involved. Let somebody start the discussion. As he's trying the slides, we'll stop the discussion once his slides are on.
Yes, sir. Sorry, I think that's...
Here is 4 children in the same family with spastic paraparesis. To me, the speed of progression from starting at 14 years, bedridden with bed sores at 1.5 years, seems to be a little too rapid for a hereditary spastic paraplegia.
David, did all the other siblings have the similar phenotype? I remember you're saying that one had cataract and the other had an ID and cataract, not the paraparesis in all 3 siblings. Is it right? Or?
Yes, ma'am.
So it's only this child was
This
presented
child
with progressive.
Not the other 3 children.
Yeah, the phenotypes are variable, sir.
I don't know why.
Right, but the speed of progression seems to be a little too rapid for hereditary spastic paraplegias. I'm subject to correction. I thought being bedridden with bed sores within 1.5 years and bladder symptoms. Second thing, in a 13-year-old child with gallbladder involvement, I vaguely tried to recollect what are those metabolic diseases in which gallbladder is also involved. Then neurologically, I was trying to recollect. I'm not able to get at it. But
Metachromatic leukodystrophy is the one which can have gallbladder involvement, sir.
Correct. So that's right. So I was just trying to see whether I can correlate those both clinically. Ultimately, you may be right, but as a clinician, I'm trying to give importance to that cholecystitis in a 13-year-old child with paraplegia.
David, you can discuss like 13-year-old child with progressive paraparesis. What are the differentials you'll consider?
Don't worry about the slides. Proceed on.
Yes, sir, 1 second.
Don't get stuck to the slides. You can extempore speak like a politician. Speak extempore freely.
Yes, sir.
So here's the spastic paraplegia. How did you proceed?
Are you there, David?
Yes, ma'am. 1 second.
So sir was asking what are the list of differentials that you would
Yes, ma'am.
consider in a
So
child with a
this,
progressive paraparesis?
Yes, ma'am. This way, she's a adolescent girl with a late onset presentation involving there were history of paraparesis along with bladder involvement, which seems to be having a UMN type of bladder, and also involving vision loss, which is a gradual diminution of vision with preserved with bilateral reacting pupils. So in this case, I would.
And she also had a disc pallor, no? She also
she
had
has
a disc
pallor, which
optic
was
atrophy.
of
Yeah.
optic atrophy. So there is definitely multiple levels of neuraxis involvement in different sites. So I would consider white matter involvement in this case because of the so milieu of manifestations that was presented in this scenario. So our differentials were. Should I go ahead with the examination, sir? I mean, I think my slides are back.
Go ahead with your slides. Yeah.
So on examination, her bulk was decreased and there was increased tone in both the lower limbs, more than the upper limbs. There was spasticity. There was the power was slightly decreased in the upper limbs, significantly lowered in the both lower limbs, and the superficial reflexes were absent, and there were exaggerated deep tendon reflexes, and both her plantar reflexes were bilaterally extensor. So her sensory system, there was decreased vibration of proprioception sense, but however, pain, touch, and pressure sensations were normal. The cortical sensation was normal. There are no cerebellar signs, no meningeal signs of irritation signs, and there was bilateral knee and ankle contractions noted, and rest of the examination system were normal. In short, the summary, so it's an insidious onset, gradually progressive course, spastic quadriparesis with lower limb more affected than the upper limbs, with the UMN bladder symptoms, and also progressive diminution of vision with optic atrophy, with no extrapyramidal cerebellar encephalopathic symptoms and preserved cortical sensations. So I'd like to localize this to a white matter disease, and considering the age and the whole clinical syndrome, the possible differentials that we would think in terms are acquired demyelinating disorders, mostly likely NMO spectrum disorders, multiple sclerosis, genetic leukodystrophies, and metabolic disorders which can cause a similar presentation are arginase deficiency, hyperhomocysteine, and biotinase deficiency. Mitochondrial diseases can have variable presentations and could present in this clinical syndrome, and hereditary spastic paraparesis plus because there was an involvement of optic optic atrophy in this case. So
Yeah,
these are the possibilities that we have considered. So evaluated the patient.
There is a question in the chat box. Did this child have absent vibration for proprioception?
Yes, ma'am. This child had a.
So why would you like to localize it? If or any of those disorders which can have absent vibration and proprioception along with optic neuropathy and subacute myelopathy.
Yes, ma'am. So this we've seen most of the diseases, demyelinating diseases, and the metabolic diseases that we enlisted had incidents of involvement of peripheral nervous system as well. So there's a neuropathic involvement as well.
So this child has a posterior column involvement as well?
Yes, yes, ma'am.
Okay.
Yes,
okay, proceed.
What is the neuropathic involvement? Predominantly, it seems to be a posterolateral column involvement.
Yeah.
Where is the neuropathic involvement?
Like a myelopathy, sorry.
Yeah, it's a posterolateral myelopathy.
Yes, myelopathy.
Thank you.
So, an evaluation of this patient, she had a hypochromic microcytic anemia, and iron studies were suggestive of anemia of chronic disease picture. The rest of the routine investigations are normal. She was evaluated for autoimmune workup, which showed all her NMOSD screen, vasculitis workup, ACE levels, and anti-TTG levels were all normal. The negative screen for that. So her metabolic workup was normal for CPK levels, ammonia, lactates, and her other metabolic workup was normal. However, I would like to mention that she was already initiated on some sort of treatment, which I would before coming here, because she was evaluated elsewhere before on arrival at our hospital. She had some proteinuria on an investigation, and her catheter sample was growing some gram-negative bacilli. So, and her CSF analysis was normal. So she was, as I mentioned, she was worked up, and neuroimaging was done outside, and which was showing this was done outside, and this was 1 year before the presentation to us. It was showing thinning of the cord, cervical and thoracic mostly, and there was some
the cord imaging actually it was a large FOV, and all we could see was some very subtle hyperintense signals involving the cervical cord and some thinning of the thoracic cord. Yeah. Okay. Go ahead, David.
Yes. So this is done at the presentation, sir, and this was there was you can see this after 1 year after the interval scan of 1 year. You can see that cord is even more diffusely thinned out, and there are some hyperintensities involving the cervical and thoracic cord as well here. This is a T2 weighted fat suppressed image of the orbit axial cut. We're showing some mild thinning of the bilateral optic nerves. And this is a T2 flare image axial cut showing there's a involvement of the periventricular white matter adjacent to the lateral ventricles, and also involvement of the posterior parietal cortex showing hyperintensities. So her neuroelectrophysiology studies showed sensory motor axonal polyneuropathy. There's her visual evoke potential showed absent waveforms. Her SSCP tibial study showed bilateral peripheral pathway dysfunction. Her hearing assessment was normal in terms of your beta was normal, and other tympanometry and audiometry tests were performed were normal. Her ultrasound abdomen showed an irregular bladder wall thickening with internal echoes within the urinary bladder. A cystometrogram, which is a urodynamic studies, was showing an poor incontinence with poor flow and an overactive bladder picture.
1 minute. What's the serum B12 level? Did you have any chance to see a serum B12?
Serum B12 was done, sir. It was yes, sir. It was done. It was normal.
No, sorry, I missed it.
B12 and homocysteine both were normal.
Both were normal.
Yeah. Sorry, I think I didn't read it. Sorry.
So her clinical exome, actually it was done at this point, showed a missense variant in the exon 4 of this gene called BTD, which is inherited in the homozygous pattern, which is causative of this disease called biotinase deficiency, which is inherited usually through an autosomal recessive pattern.
1 minute. What made you suspect to do a clinical exam? Is it as a part of a paraplegia panel, or what prompted you to do this?
Actually, yeah. So I think so the list of differentials as we considered were, I mean, initially or all the autoimmune workup, everything was negative, and also this other list of differential as we considered included hereditary plastic paraparesis, and also there is involvement of other metabolic conditions which we wanted to rule out.
No, this child actually, sir, was evaluated extensively in Patna before coming to us. So there is a consanguinity, and two other siblings had other phenotype. One had ID, another had cataract alone. One had ID with cataract, another had cataract. So this our proband had presented with progressive vision loss and also had this myelopathy with bladder involvement. Considering all the consanguinity history as well as the positive family history in other siblings, and all the autoimmune workup and NMOSD workup being negative, the neurologist who have seen this child in Patna himself has sent for the clinical exome study considering the possibility of late onset biotinase deficiency. The child was already started on biotin when she came to us. She was on 20 milligram BD of biotin, but there was a near complete recovery of vision, but the myelopathy was persisting. Like she was left with a sequel, like she had paraparesis with neurogenic bladder. So we proceeded with the confirmation of the diagnosis because this variant was reported as VUS. So we did the enzyme assay, which was showing a significant profound deficiency. You show the enzyme reports.
Now, what I want is give for others a take-home message when to suspect biotinase deficiency, so that people will be more alert and not ignore it as hereditary spastic paraplegia. That's what I want you to give us a take-home message when to ask for biotinase levels.
When you biotinase deficiency has two typical to presentation. One is classical, another is the late onset. The classical one it presents with the presentations like refractory seizures, developmental delay. The seizure semiologies could be variable, ranging from myoclonic seizures, epileptic spasms, focal motor seizures, or other generalized seizures. And they have the seborrheic dermatitis, they have eczema and the flexural dermatitis. They can have perianal rash, and they also have vision impairment, optic atrophy, and also have hearing impairment. This is the classical presentation in the early infantile period. And if you look at the MRI can be showing a delayed myelination or hypomyelination. And when you do the urine organ, when this child present with an acute state, any child presenting with an acute decompensation, you will always do a panel of investigations. So it goes by the acronym GLAC. You look at the blood glucose level, E is for electrolytes and acid-base imbalance by doing arterial blood gas, and L is the lactate, and A is the ammonia, and K is the ketone. So it goes by the acronym GLAC. So you look at the acid-base imbalance. They develop metabolic ketoacidosis with elevated lactate. They can have mild elevation of ammonia in the acute phase, and they can have positive ketones on urine with low blood sugar. And if you look at the typical clinical pattern with this typical skin manifestations and refractory seizures, biotinidase deficiency should be considered, and you can do an enzyme assay. If you have not done a newborn screening, this might be missed, but many of the cord tests which is done in the newborn period picks up the biotinidase deficiency as well. There are two type of enzyme deficiency which can have a clinical overlap. One is the biotinidase deficiency, other is the multiple carboxylase deficiency. So both of them will have a similar clinical phenotypes, but the biochemical parameters would be different. The multiple carboxylases deficiency, you have deficiency of multiple carboxylases, including pyruvate carboxylase, acetyl-CoA
Geeta,
carboxylase.
I think this David has some slides on that. You want to
Sure,
show
sure.
that, David?
Yes, ma'am.
Just show that this thing, that
Yes.
metabolic pathway alone.
Yes,
It's because
okay.
we are running short of time.
Yeah.
Sure,
You can just show that, yeah.
So yeah, so biotin we get it. It's really available from the diet, and the clinical condition we are talking about is this biotinase deficiency. This enzyme is mainly responsible for recycling the biotin, which is absorbed through the diet. Usually, when the biotin enters through the diet, it just comes as a free biotin, and it's picked up into a free apocarboxylases with the help of this enzyme called holocarboxylase synthase. So this incorporates this, and this holocarboxylases help in the various metabolic pathways which which are used up. So this biotin has to be recycled back into the bloodstream with this help of this enzyme called biotinase. So both these enzymes are the ones which take in and release the biotin into the blood. So how do those manifestations and the metabolic parameters pop up in with the deficiency of biotinase enzyme is because this biotin helps in all the major metabolisms of amino acid, lipid, and gluconeogenesis. So all the glucose, fats, and lipids metabolism is involved, and that happens with the help of these 4 carboxylase enzymes. All the 4 carboxylase has biotin as a cofactor. So it helps in leucine degradation, isoleucine degradation. It helps in fat metabolism. It helps in gluconeogenesis. So this is also a fat metabolism. Eventually, so when this biotin is not available, these metabolisms are hindered, and the metabolites go up. So the clinical features, as Sir was asking, mainly can categorize into 2 systems, mainly neurological and dermatological. And the phenotypes are two types. I mean, one is an early onset, the other is a late onset. The early onset, usually with a very severe biotinase deficiency, comes as early as in neonates, but the mean age of presentation is around 3.5 months. They come with seizures, hypotonia mainly. These are the main 2 presentations. Seizures are polymorphic. They can be anything from myoclonic, GTCS, focal and epileptic spasms, and a hypotonia, which is the predominant symptom. There can be a spinal cord involvement and other neuraxis symptoms of cerebellar and developmental delay because of hypomyelination, hearing defects, and optic defects. All these can occur. But one thing to be noted is this early onset disease has cutaneous manifestations, which is actually a very evident pointer. Even in some cases, even before the onset of neurological symptoms. Whereas in late presentation, usually it's rarer than the early onset. Usually the deficiency is partial, that's why they come late. But of course, often there are good number of cases with profound biotinase deficiency, which can remain asymptomatic till adolescent age group. They have predominantly neurological symptoms, and they usually come with progressive optic atrophy. These are the common presentations. They can be any levels of neuroaxis involvement, but optic atrophy, optic neuropathies, myelopathies, leukoencephalopathies, they can be coming with hearing loss, and even late onset seizures has been reported. So this is a study which is compared with compared and reviewed cases of biotinase deficiencies, particularly in the late onset, where the onset is above 5 to 7 years in the adolescent age groups across different ethnicities. Is Chinese study, and this they compared, and this is to basically point out where the axis is primarily and most predominantly involved in this condition. So there is involvement of peripheral neuropathies, there is involvement of myelopathy significantly in late onset forms, and very interestingly, most of the times cervical and thoracic are more predominantly involved, and there could be a brainstem disease with brainstem dorsal and midbrain presentation as medullary representation. And this particular patient, they came with sighing, respiration, and paraparesis. There is optic tract involvement, which is very commonly seen along with the myelopathies and the leukoencephalopathies, which is seen. So, yeah. So during the evaluation, the four main.
You go on to the next slides, David.
Yeah.
Treatment. Go on to treatment. Yeah.
Yeah. So the biotinase enzymatic is the most specific test. Which is a very simple test. And there is genetic testing which can detect this enzyme deficiency. And the treatment is a very good when we get this. The treatment is supplementation of biotin lifelong. It's a very much curable neurometabolic disease, and the goal of the treatment is to start as soon as possible. The recommended dose is 50 to 20 mg orally, depending upon the weight, and it can go up to maximum 40 mg was used for patients. Carriers would not usually need therapy. Their levels are usually seem to be lower in some carriers, but they would not require therapy. So since there's involvement of neurological deficits involving hearing and vision, so regular ophthalmologic evaluations, interventions, hearing aids, cochlear implants could improve the overall life of the patient's mobility. So developmental interventions might be required because these child fall short in attaining their milestones. And also, the very important thing in this is the early pickup and early diagnosis and treatment, because that itself will prevent the onset of the disease itself, and the children can remain asymptomatic, and no need of restricting any proteins because there's an increased metabolites. So some of the diet which can directly inhibit biotin uptake is evident, which decreases bioavailability in the diet. So it should be raw eggs which contain this should be avoided. So the prognosis in this condition is excellent. If the treatment is started before the onset of symptoms, they would remain as normal as a well child without even developing the symptoms. And even after the onset of symptoms, there's a significant reversal of symptoms in terms of dermatological and symptoms. The alopecias, the brittle nails, the sparse eyebrows, and acrodermatitis, the perioral seborrheic dermatitis, perioral rash, all these, they significantly respond. Even there's various reports in the literature stating that there's reversal of neurological symptoms, at least the improvement of symptoms can be expected. This is also one of our patients. It's not this particular case. This is an early onset biotinase deficiency where you can see alopecia, this sparse eyebrows, and some very oral rash as well. This is after the initiation of treatment. The cutaneous dermatological manifestations, they actually respond very quickly. I mean, within the response, you would start about 3 months after the initiation of treatment. In our particular patient, since she was started on biotin, but we optimized it after coming to after she presented at our center. Optimize the doses, and so there's a significant improvement in the vision which was noted, and the upper limb power is also significantly improved. They describe it as 90% improvement symptoms from the onset. and she can now sit with without support. Earlier she used to take support to turn around and sit, and would require somebody to make her sit, and she became completely non-ambulant. So she now she is walking. We could not get the video of the child, but so now she's ambulant, and she just with some walker she was able to move around by herself. Because of the contractures, she's little restricted, but she's significantly improved. So
Okay, go to your last slide. Yeah.
So the important take-home message I would like to put forward through my presentation is, this is if you have to choose a neurometabolic disease, this is the one which you have to choose, because it's a very curable and treatable condition. So it's preventable and completely treatable almost. So an enzymatic assay, which is very simple, rapid, it just needs a dried blood sample. It's very specific and robust thing that is available. And this is a presentation in a teen with paraparesis, as sir was asking. So spastic paresis, this should be considered as a very important differential, because this is one of all the list there mentioned there with so much of morbidity and expensiveness of treatment. This treatment is very simple and cheaper, and it's also almost very much treatable. So this should not be missed and should always be included in the list of differential for spastic paraparesis. So that concludes my presentation.
Thank you. Today you have highlighted 4 important cases. What is more impressive is suspect biotinidase deficiency in every paraplegia is a very good take-home message for every pediatrician in the practice. Second thing, early diagnosis of adrenoleukodystrophy in a healthy, unaffected sibling is again an important message. And then early consideration of refractory focal seizures for epileptic surgery, again an important message. So all your cases have had very good take-home message for a practicing pediatrician. I thank the department for an excellent selection and presentation. Dr. Maya Thomas.
Thank you very much, Dr. Kumaresan, for your encouraging comments. And I would like to thank Dr. Natarajan for giving us this opportunity, and also, a lot of active participation from all the pediatric neurologists across the state. Thank you, Dr. Lima, Dr. Neekandan. Thank you, Dr. Ramakrishnan. Thank you very much. Thank you, Dr.
Madam.
Sangeeta.
Excellent presentation, madam. Thank you.
Professor Maya,
Yes, sir.
Professor GK's comment were not only encouraging, but factual. It's a factual comment.
Yes.
Thank you very much.
Thank you so much.
For educating, and please continue to educate us.
We
Thank you.
continue to learn. We continue
Yes.
to learn every day.
Yes, sir. Yes, sir.
Thank you,
Completely.
Professor GK, sir. Thank all the participants, Professor Lima, Professor Megandan,
you, ma'am.
Ramakrishnan, Vijay, and all those who took part in the active discussion. Thank you all. And above all, thank you, Sun Pharma, for continuing to stay with us and providing the logistics support. Thank you very much.
Thank you, sir.
Thank you very much.
Thank you, sir. Thank you.
Thank
ma'am.
you.
Thank you.
Signing off. Yeah.
Thank you, sir.
Yes.
Thank you to all the presenters also.
And yes,
Good job.
thanks to all the presenters and also to Sangeeta madam. And also to Sangeeta madam. Thank you.
Yeah.
Thank you.